So what is heart failure? Now, if you look to the left of your hand, the heart failure is basically symptoms and signs of heart failure. That is something which is the first point. So look at the first line, doesn't involve ejection fraction there. So it is symptoms and signs of heart failure, which are caused by either structural or functional abnormality of the heart. So heart may be structurally abnormal, there may be mitral valve disease, there may be left ventricular hypertrophy, there may be chamber enlargement. So these are structural issues. Or sometimes heart may be structurally normal, but there are issues with the function of the heart. Say for example, during diastole, heart has to relax, heart has to expand well to adjust with the fluid which is coming to the ventricles. So these ventricles, if they are not functioning well in terms of they are not dilating well, if they are not relaxing well, that also can lead to signs and symptoms of heart failure. So symptoms and signs of heart failure caused by either structural or functional abnormality of the heart. So that is basically heart failure. But you need to have some objective evidence. Either one of these. Number one, there has to be elevated natriuretic peptide levels. So most of the patients where you have doubt about diagnosis of heart failure, these tests should be sent. Previously, in the old days, before 5-7 years, we were not using it frequently, but now we all are using very frequently. Or if you have not sent for BNP or NT-proBNP, or if they are normal, we can get certain other objective evidence of cardiogenic, pulmonary or systemic congestion. So patient has cardiogenic pulmonary congestion, you have to document it through your X-ray test or some other test. So basically signs and symptoms, structural functional abnormality of heart with BNP elevated or with cardiogenic or pulmonary systolic congestion. What are the symptoms of heart failure? They have been quite age-old. Framingham, in fact, defined this criteria before many years, and they divided criteria into major and minor. I won't go into the details, but they help you to get the diagnosis. Point number 2. So how the heart failure is now defined. Once you have a patient who has got signs and symptoms of heart failure, where you believe there is some structural or functional abnormality of the heart, then based on ejection fraction and certain other parameters, we divide them into 3 parts. Number 1, HFrEF, heart failure with reduced ejection fraction. Number 2, HFmrEF, that is heart failure with moderately reduced or mildly reduced ejection fraction. Somebody also says heart failure with mid-range ejection fraction. And third point, which is of interest today, is HFpEF, that is heart failure with preserved ejection fraction. So in these patients, there will be signs and symptoms of heart failure. Patient might complain of dyspnea on exertion, patient might have penial edema, patient might have raised JVP, patient might have liver, etc., etc. But on echo, ejection fraction is 50% or more. So that is something very important. Along with that, there are certain other objective signs. What are they? As I discussed, it can be elevation in natriuretic peptide, or there can be some issues with the echo. What are the echo points? Those who are quite comfortable with echo. One is increase in LV mass. We won't go into the micro details, but left ventricular hypertrophy or increase in LV mass is one point. Second is dilated left atrium. So left atrium normal dimension, if it is more than 40 in millimeter size, most of the times in our echo report, we do not go to the volume of left atrium. But when left atrium dimension mentioned more than 40 millimeter, think that LA is dilated, and then there can be diastolic heart failure. And there are certain more refined tests on echocardiography, that is E/E ratio or pulmonary artery systolic pressure. Most of you are aware that we do mention on echo RVSP, right ventricular systolic pressure. So if it is more than 35 millimeter of mercury in the absence of pulmonary stenosis, that is called as PAH. So LA volume enlargement, LVH or LV mass increase with RVSP elevated in a patient who has got ejection fraction more than 50%, but signs and symptoms of heart failure, think of HFpEF. So this is very important point. Number 3, we generally believe that there are very less patients of HFpEF. But if you look to the international data, now in the world, in the Western world, especially America and Europe, they are getting almost 50% of patients who are hospitalized with heart failure as HFpEF. So if you have 10 patients admitted with heart failure in CIMS, then they say that 5 would be HFpEF and 5 would be HFrEF. Now, it is not that strong statistics here, but in India also we are getting now more patients of HFpEF. Why we are getting more patients of HFpEF? Number 1 is increased longevity. There is a direct relationship of HFpEF with the age. So as the age is more, you get more chance of HFpEF. Basically, HFpEF is a disease of systemic inflammation with lack of elasticity of vessels in heart. So as the age increases, my heart will become less elastic, less flexible, it will become more stiff. Similarly, my vascular structure, my arterial tree will become less elastic, will become more stiff. And there is some systemic inflammation going because of some other comorbid conditions. So aging is a very important point. Second point is increasing comorbid conditions. Each and every comorbid conditions can lead to something called a systemic inflammation. Say, for example, COPD, thyroid disease, obstructive sleep apnea, chronic kidney disease, chronic liver disease. So when all such disease or one of these diseases is there, it induces a state of systemic inflammation, and that's where chance of HFpEF increases. And third is now we doctors are more aware that such a situation exists, and that's why we diagnose that. What about the prognosis? Most of the times my medical officers, they call me, say patient has got HFpEF, they are happy. Ejection fraction is 55%, and they generally come to a perception that you should not bother much. Patient has heart failure, but EF is 55. But look at here, this is a data from again Western world. These were the patients who were admitted with heart failure, either HFrEF or HFpEF. They were discharged and they were followed for 10 years. And look at the mortality. Mortality is same. Whether you are admitted with HFrEF or HFpEF, once you had a serious disease which required an admission to the hospital, that means now your prognosis is same. So your ejection fraction may be 55% with heart failure and you got admitted, or it may be 25 or 30% and you got admitted. Your overall long-term prognosis is same. So ejection fraction loses a value as far as gravity of diseases or prognosis is concerned. So don't always get guided by ejection fraction because we are too much EF centric. So when patient has heart failure, patient has severe heart failure, needing admission, whatever the EF is, the patient has poor prognosis. So that is something which is very alarming. Fifth point, if you look to the patient of HFrEF, most of them die because of the cardiovascular conditions and disease. They die because of arrhythmia, they die because of sudden cardiac death, they die because of progressive heart failure. But if you talk about patients of HFpEF, look at here, 50% of them die because of non-cardiovascular disease. What did I say? That HFpEF is a disease of comorbid conditions. So when patient has chronic kidney disease, patient might get HFpEF, but he or she will die because of CKD. Patient with chronic liver disease would get HFpEF. Again, they might die because of liver-related issues, COPD, obstructive sleep apnea. So this is very important. So HFpEF patients, when you manage them, you need to manage HFpEF, but at the same time, you have to pay attention to the comorbid conditions also because it is going to be the cause of death in them. Number 6, what is the role of echocardiography in diagnosis? Very, very important role. Number 1, first you have to prove that ejection fraction is 50% and more. Second, you have to prove there is left ventricular hypertrophy, left atrial dilatation. Maybe sometimes patient might have RWMA, patient might not have RWMA, and then ultimately you define it as a diastolic dysfunction. There is a beautiful scoring system. See, when we talk about HFpEF, most of the times we all diagnose heart failure and get it re-endorsed by the ejection fraction. So when you see a patient with dyspnea on exertion, pedal edema, etc., you send a patient for echo, ejection fraction is 25%, you are happy that you have diagnosed a condition of heart failure. But in same patient, if ejection fraction is 55%, whether it is HFpEF or something else, whether it is CKD, whether it is anemia, whether it is chronic liver disease, whether it is COPD, obstructive sleep apnea, then there is huge number of conditions which can be there. So it's very important to look at the probability of HFpEF, and this is a scoring system. The scoring system is easy to remember. It is again HFpEF. So H, there are 2 points on H. One is those who are obese, they get 2 marks, more than 30 BMI. And those who are hypertensive with 2 or more medications, so significant hypertension, they get 1 mark. F is atrial fibrillation. So when you have got atrial fibrillation, either persistent or paroxysmal, you get 3 points. So what does it mean when you get a patient of non-valvular atrial fibrillation? Non-valvular atrial fibrillation, think of HFpEF, which is there because see, it gives you 3 marks immediately. So atrial fibrillation. Then pulmonary hypertension, as we discussed on echocardiography, elderly is more than 60 years. And there is specific test on echo again, which is filling pressure E by E prime, that is done by a cardiologist, but they can do this. So these are total 9 points. So if they are 0 or 1, HFpEF is not there. If they are between 2 to 5, the chance is very high. And 6 or more, it's almost there. So what does it mean? You have a patient who is got 65 years of age, who has non-valvular atrial fibrillation, and who is on 2 medications for blood pressure. See, he or she is HFpEF. So this is, once there is non-valvular atrial fibrillation, it's very, very important to make your antenna open, that this patient can have HFpEF. So this is a very important score. Number 8 point, how does it gets managed? So till 2019, we didn't have any specific medications. How did we treat that? Consider alternative diagnosis, because at that time HFpEF was not that well thought. Symptomatic treatment by diuretic. You can use loop diuretics, potassium sparing agents. Initially, you might need little higher dose to get rid of extra water. But then once a patient has got rid of extra water, you have to reduce the dose of diuretics, because these are the patients whose cardiac output is filling dependent. So if you make them too much dry, their cardiac output is going to go down. So ultimately what I say is touch of diuretics, touch of, like say Diator plus 5 milligram half, or Diator plus 10 milligram half, something like that. Treat blood pressure and other comorbidities. That is very, very important. To reduce the symptoms of the patients with HFpEF, you have to reduce their blood pressure to a level of less than 120/75. Don't be satisfied at 140/90. Take them low. Treat obstructive sleep apnea, COPD, kidney disease. Rate control in atrial fibrillation. If you can maintain sinus rhythm, it's good, because atrial kick contributes to the cardiac output more so in patients with HFpEF. So try to see to that patient is in sinus rhythm, or at least control their heart rate to a resting of 60. So it's very, very important in almost all cardiac disease. Try to keep a heart rate as close as to 60 per minute. That's where heart is feeling happy. Treat ischemia, and 2 drugs were having some data, that is spironolactone and ARB. Not very conclusive, but spironolactone and ARB were the 2 drugs. Point number 9, of late, in last 2-3 years, 2 drugs have got some good data. One is ARNI, that is Vimada or Sigmus or whatever we say. It's a combination of valsartan and sacubitril, and the trial had a significant, borderline significant reduction in composite endpoint of heart failure and death. It couldn't reach the p-value of 0.05, but in at least 2 groups of HFpEF, it could reach a p-value of significance, that is female and ejection fraction 50% or more. So I do use this drug, which is very important. And second drug which has come on the surface is empagliflozin or dapagliflozin. That is also a very important drug. When you give this drug to patients of HFpEF, there is reduction in composite endpoint of death and heart failure. Because see, when heart failure we discuss, 2 parameters are very important. One is people die because of heart failure, and second, people do get repeatedly admitted because of heart failure. So when you give these 2 drugs, ARNI and EMPA-DAPA, you reduce the risk of readmission, you improve their symptoms, and you also might touch a little bit of their mortality. So coming to sort of conclusions, ladies and gentlemen, HFpEF accounts for almost half of the total hospitalized patients of heart failure, and it is increasing. Mortality in hospitalized patients with HFpEF is as high as HFrEF. So whenever you see a patient who is admitted with HFpEF, he or she is as serious as HFrEF. HFpEF patients have poor quality of life and very poor exercise tolerance. Comorbid conditions, as I discussed, drive the systemic inflammation, and ultimately it leads to remodeling of heart and remodeling of vascular system. Treatment of comorbid conditions and touch of diuretics are the traditional ways, and 2 new drugs have come on the surface, that is ARNI and SGLT2 inhibitors. So both of them are quite good, and they should be used in every patient where there is no significant contraindication. And something which is very important, many aspects of HFpEF are still under doubt, and we are not understanding them well. In fact, at the moment, world is not very clear what this P means. So what is the cutoff of HFpEF? Is it 50% EF? Is it 55? Is it 60? But I personally believe, based on my review, that now science is going to have only 2 points, HFpEF and HFrEF. 60% or more EF will be ultimately called as HFpEF, and 60%, less than 60% EF will be considered as HFrEF. That's where science is going. Thank you very much for your kind attention.